what is the role of CRRT in the ICU patient? Because that's really the only place where it's truly appropriate. Well, what is wrong with CRRT, I think, is the question that I think needs to be answered, because I have a hard time understanding why it is not more universally used. Now, it's like anything, it's not appropriate in every circumstance, but in my view, CRRT is grossly underutilized in the intensive care unit, and especially with patients that are on ECMO. So it stands for Continuous Renal Replacement Therapy, CRRT. Therein lies the first and most significant problem with this therapeutic modality. Because what that does is it almost exclusively pushes it into the purview of nephrology. And you see here, it is mostly managed by nephrologists. However, there are some nephrologists, because their fellowships don't teach CRRT, or their fellowships actually taught that CRRT was not a good therapeutic modality for whatever reason, there are turf wars between intensivists and nephrologists. These are not really uncommon. I have seen places where ICUs, the CRRT in the ICU is managed exclusively by the intensive care medicine department, and nephrology had absolutely nothing to do with it. And I've been places where ICU medicine, for some reason, has nothing to do with it. They want everything to do with it, and they can't, because it has been shoehorned into the purview of nephrology. And I think this is a gross misconception of what CRRT is. So what's wrong with it is the name to start with. It should have never been called CRRT. Basic misunderstandings about the therapy are frequent, and thought that it is sled, which is a type of dialysis done on a standard intermittent dialysis machine, which is slow, low efficiency dialysis. And a typical dialysis therapy lasts between 3 and 4 hours if the patient is stable enough. Sometimes it has to be aborted sooner, but sled will last 8 to 10 hours, maybe as long as 12 hours. So again, the problem with that is, I'll ask Dr. Zubieta. Dr. Zubieta, how many hours a day does a kidney actually work?
When it's working?
When it's working, yes. When it is working.
24.
It's intended to work all day, every day, right? The problem with these therapeutic modalities that are intermittent, even if you talk about sled, is it's between 2, 3, 4, maybe as high as 8 to 10 hours. That is hardly what the kidney actually does. Non-renal, like CV surgeons and anesthesia, do, when you explain it to them, because a lot of these people are very busy, they're not interested. Dr. Samir, you're one of those people. You know, you do understand it because you have that mentality. Nephrologists, though some of them are brilliant people, I mean, as far as I'm concerned, but understanding the critical care patient in the ICU, on ECMO, multiple pressors, all of these things, not that nephrologists aren't smart, but they have a very narrow focus and not really looking at the milieu, if you will, of the patient and all of these other things that all are interacting with either the kidney or that the kidney is interacting with. Perfusion, we understand it really well, but some of them don't want anything to do with it because I don't want to do this. This is renal. This should be a dialysis nurse. This should be a dialysis tech, whatever they want to say. So I think all of these people who have this perception that they don't want to do something when it comes to this extracorporeal therapy that manages inflammatory mediator removal, manages fluid balance very precisely, manages electrolytes very precisely, removes metabolites very efficiently, corrects acid-base problems very efficiently. I think it's very misguided. Instead of calling it CRRT, it should have been called extracorporeal physiologic something machine. What's the word I'm looking for? I'm trying to find the word. I can't think of it right now. You got to help me out here. Stabilizer, normalizer. I don't care what you want to call it. Fluid, electrolyte, acid base, normalizer, and inflammatory mediator removal. Critically ill patients in the ICU. Well, what do we deal with all the time? We deal with pressure. We deal with the cardiac output and cardiac index. Deal with perfusion. You know, the talk we're going to give on the 10th, and with this new microvascular camera tool that we have that we're going to look at, and you're going to help me with getting some good patient data for the folks in Amsterdam that sent me that device, is going to be very important. But it's very easy to have a good blood pressure, even a good cardiac output and cardiac index, and have horrible perfusion. You can even have what seems to be an inadequate blood pressure and inadequate cardiac output, you think, but the microvascular perfusion is really very good. I think one of the biggest things we do poorly and should do better is that we do not image enough in the ICU, whether that be even in bypass for the hearts. We don't do transcranial Doppler. We don't do microvascular circulation evaluation. We don't measure the arterial saturation in the appropriate points, especially when we are on VA ECMO and you're worried about differential hypoxemia. There's a lot of things that we don't do well, and we infer a lot of stuff from other things when we probably should be directly measuring it. That's what I believe. We deal with fluid management. We deal with acid-base derangements. We deal with electrolyte derangements and a multitude of other things, including multi-organ system failure or organ failure as a whole. So fluid is a big, big problem. Excess fluid is an even bigger problem. It's much easier to get it in than it is to get it out. There is no question about that in my view. When you have fluid overload, you develop cerebral edema, which causes impaired cognition and delirium. Myocardial edema, which means you get conduction disturbances, atrial fib, so forth, impaired contractility, diastolic dysfunction. Pulmonary edema, your lungs don't work as well, reduced compliance. Of course, if you're on the ventilator, you're going to have a higher risk of barotrauma, lower gas exchange, increased work of breathing. If the patient isn't intubated, they become tachypnic, and we see that they become exhausted, and then you have to intubate them in a hurry. And that I've seen patients. I have had a patient that was lying in the bed. He was maybe 4 days post CABG surgery. He was just breathing really heavy, looked bad, and they wanted to intubate the patient. The surgeon told me, look at his x-ray. We looked at his x-ray. His heart was huge. His lungs were wet. The dude was clearly in pulmonary edema. We put a Maherker catheter in. I hooked the hemoconcentrator up to just a straight roller pump. I removed, I think, 6 liters of water off the patient over, 18 hours, 16, 18 hours. But within the first 2 hours of treatment, he was sleeping comfortably. I removed the first couple of liters in a hurry, and he immediately got better and improved. And it was convincing to me that this is a therapeutic modality we need to be using more of. You get renal interstitial edema. That causes, of course, a decrease in renal function. Hepatic congestion, we all know what happens there. Gut edema, big, huge problem, because gut ischemia is a real big problem. And tissue edema. So these are all the things that happen when you get fluid overloaded. Survival is also grossly affected. In fact, there's a lot of work that's been done that shows fluid overload is an independent predictor of mortality. And you can see here that fluid overload of equal or greater than 10% has an appreciable, especially over time, appreciable increase in mortality. We've all seen this picture. That's what it looks like. You see her eyelids appear to be water balloons that you could grab and throw at somebody that you didn't like or wanted to mess with. But the hard fact is that when you see a patient that looks like that visually, and this is I can't remember who said this, a quote by somebody. I don't want to I think it was Dr. Ronco, I think. But I want to make sure that I say, this wasn't my phrase, I stole it from somebody. I think it was him. Anasarca is not only a visually displeasing finding, because if that's what she looks on the outside, that's what her organs look like on the inside, and they're not gonna work very well. You're gonna have perfusion deficits, all kinds of problems are gonna occur, and you're gonna have organ dysfunction secondary to it. Acid base. When you have an acid base problem caused by lactate, it is a big problem. Now, notwithstanding, you have to solve the problem of the hyperlactatemia. You have to figure that out, okay, and fix it. You can't just clear it. But lactate on its own can create a lot of problems. In fact, you leave the lactate up high enough, long enough, you'll go into ARDS just secondary to hyperlactatemia. Is that correct? Dr. Z?
Not necessarily.
Not necessarily?
No. I mean,
You don't think so either?
lactate is a marker, and one of the biggest mistakes that we're making these days is that we are labeling things. Now everybody who has a high lactic acid is in need for some specific interventions. That is not necessarily true. You have to remember the Cori cycle. And the Cori cycle is taking the lactic acid that is coming out of the glycolytic pathway back to the liver and convert it back into citrate. So patients with liver dysfunction, in general basis, will have what is called a type 2 lactic acidosis. Or it's not lactic acidosis, it's actually hyperlactatemia that the patient has, and it has nothing to do with microcirculatory perfusion or cellular hypoxia or cellular anoxia. It is very important at the beginning, especially when the numbers are high. You need to actually make sure that the high lactic acid that you are measuring is reflecting a state of low oxygen at the cellular level.
Yes, agreed with that
That
it's an ischemic issue.
Okay.
That it's yes. So,
but the question was
but
whether
I was well. Here's what I was trained. Let me tell you that, and then you can give me that opinion. I was trained if we have a trauma patient, and they have a very high lactate level, or you have somebody who has exercised themselves into a lactic acidosis, that if you do not clear that lactate, that lactate will lead to ARDS. Now, that's how I was trained.
no.
No, that's not true.
The concept is wrong.
I agree.
What you need to actually do is that if the lactic acid does not clear, is because the insult is perpetrated over time. So the lactic acid is telling you, or an improvement in the lactic acid is telling you that your intervention, whatever you're doing, whether it is a liter of normal saline, or is clamping a femoral artery that is pouring out blood, or is giving some red cells, or is using norepinephrine, whatever the intervention is working.
See, now I disagree with you, and I'll tell you why I disagree with you. If you have a gut ischemia and the lactate level comes back 5, and you pour in 2 or 3 liters of saline and you recheck your lactate and it's 3.8, that intervention hasn't helped at all. The ischemia is still there. The lactate's still being produced, but you have only managed to dilute it. Same thing with CRRT. You will mask a problem by clearing lactate efficiently. Dialysis would do the same thing. You clear the lactate, but
I'm
you're
gonna have to
not,
disagree
but you're
strongly
still
on
producing it.
I'm being quite a good boy, but I can't anymore.
That's all right, go ahead.
Okay, so you have an ischemic injury, like you have a dead gut. You can give 6,000 liters. You can keep the whole Kroger water. You're not gonna clear that lactate.
Well, if it's okay, a dead
Yeah.
okay.
Well,
how
we
about
just said
a,
that gut,
how about
yeah.
a portion? You have
Yeah.
gut ischemia. I didn't
you have
say you
something
have
that-
a
you have
whole
something
dead
that's dead.
whole
You have
dead
something that's
bowel.
dead in your belly. You can give as much food as you want.
We're talking about apples and
Exactly.
elephants.
Exactly.
Yes, I know.
One thing is, there is no medical treatment for a surgical patient.
Correct.
Okay.
My point
So
is
if
you have to
Let me
correct the
finish.
problem.
Let me finish up. If you have a dead gut, your bowel is dead, you need to get a surgeon who comes with a knife and get the bowel out, or
Yeah.
the patient is dead.
Yes.
And the lactate will keep
Surgical
going up. Yeah.
patients need surgeons.
Yes.
The medical management of the lactic acid of a patient who is having microcirculatory dysfunction is a different story.
Yes.
And that is actually, if we put it in that perspective, then I would say that there are three types of hyperlactatemia. The hyperlactatemia that is by regional hypoxia, because there is a dead leg, or there is a dead gut, or there is a dead liver, or there is a generalized hypoxemia at the cellular level, that is the lactic acid that we want to address, that we want to resuscitate in the first hour. And there will be what I call the type B, that is when the liver fails to convert the lactic acid into citrate, so put it back into the Krebs cycle. When you have a patient who is a candidate for a liver transplant and is on a waiting list and is status 1A, and this patient is having a high lactic acid, you can or you cannot give the fluids. The lactic acid is not going to clear because you need the liver to clear it, and it's not going to clear. Now, that elevated lactic acid is not telling you that you have to improve the microcirculatory perfusion. What it's telling you is that the liver is struggling. As a matter of fact, you will see liver transplant centers that use lactic acid as a marker of rejection in the acute post-transplant phase, in the first 6-12 hours. The patient comes from the OR already with a lactic acid measure, and we're going to measure it every hour. So we're not going to only look at how much bile the patient is making, we're going to look at how much lactic acid this patient is making, and we're going to look at the AST, the ALT, all those combined with the INR will actually tell us, okay, is the graft working or the graft is not working? But your question or your original statement is that the presence of lactic acid in blood will produce ARDS, and I think that there is no right now any evidence that is toxic. It's actually a bioproduct that is totally normal of the glycolytic pathway. Mm-hmm. So if it's normal, if a normal product of the glycolytic pathway, it could not be toxic. Now, what happened in ARDS with somebody with a dead bowel or somebody with a bad shock, what happened is that there are too many pro-inflammatory mediators that will attack the lung and will put the lung in a situation where the lung fails either from the hypercarbic point of view, or it will fail from the hypoxemic point of view, which is the most common one.
I'm gonna look this up, but that could be, I'm gonna look it up, but it could be that, of course, we weren't measuring inflammatory mediators back then. We didn't really fully understand them, and maybe there was an inference of this lactic acid increase is combined with these other factors. But I'm gonna
Don't look it up.
this
I'm telling you wrong. You know why?
Okay.
Because let me tell you, if that's your statement is correct,
Somebody
then
cut Dr. Samir's mic.
if the statement, your statement is correct, then at Memorial Park, where I'm setting up the tent for the Houston Marathon,
Yes.
I should have vents for everybody because
No,
it's
you
going
should
to
have
be an RDS.
CRRT machines.
I know we
to
don't need
clear
that.
it. Okay,
we just take them to the hospital. Brutus will take them slowly.
If you see
then they're fine.
if you see on my slide here, I'll get back to my slides now. On my slides here, you will see that an elevated lactate over time, if not corrected through whatever means, for whatever the reason is, and this came out of the Egyptian journal. These are your folks, okay? Maybe Egyptian physiology is different.
Unless they're Houstonians,
that-
Houstonians are my folks.
Leaving lactate elevated alone is detrimental to survival in this particular study. So here are the common electrolytes we look at in the extracellular fluid, the column on the left, normally what we see. So what about CRRT? Well, CRRT is nothing more than really an umbrella term for an acronym soup, if you will. You have SCUF, CVVH, CVVHD, and CVVHDF. So SCUF is sustained continuous ultrafiltration. Its purpose is to remove fluid only. And that fluid that is removed is, to Dr. Zubietta's point, isotonic. If the sodium of the blood is 140, the sodium of the effluent that is removed will be 140. Potassium the same. It has no direct change to any electrolytes at all. It does not differentially affect any of the electrolyte concentrations. CVVH is continuous venous hemofiltration. This is used, and I'm going to talk a little bit about diffusive versus convective clearance here in a minute, but that is used for everything. Fluid management, it's used for electrolyte management, used for acid-base management, basically homeostasis of those things that are contained within the blood and blood plasma up to about 50,000 microns, or 50,000 Daltons, I'm sorry, in molecular weight. So it's very good for very small and very large. The pro-inflammatory mediators tend to be much larger molecules. I have CVVHD and I have it crossed out because that is nothing but the same as SLED, and it is diffusive clearance only. It is pointless in my opinion, and I see it being done all of the time. But if you're going to do that, you may as well just do standard renal dialysis, intermittent dialysis. CVVHDF is, really when you're in a whole lot of trouble and you need maximum therapeutic volumes. So when you replace fluid, the CVVHDF gives you the opportunity to have every single one of the pumps running, and your effluent prescribed volume can be much, much, much higher than in any of the other therapies. So let's talk very quickly about clearance. There's diffusive clearance, which Dr. Z talked about. You have blood on one side, you have a solution on the other side with different concentration gradients. Things move across the membrane and go out in the waste. You can increase the amount of water removal as well, but having this dialysate basically gives you a concentration gradient. We're all very familiar with diffusion, so I don't want to spend a whole lot of time on it. Convective clearance is a little more complicated to understand. What that is a solute drag. And what that means is, instead of a concentration gradient, you're now dealing with a pressure gradient. And the pressure on one side of a semi-permeable membrane is significantly higher than that on the other side. And there's a pump head, usually a roller pump head, in the area where you see on the left with the yellow on the top to waste, that is actually used more as a dam than as something that pulls anything across. So you want to control the volume being removed, and to do that, if you had it just free flowing, would be very difficult to do. So there's a pump that does that. And then you replace the volume, the plasma water removed, with a solution that looks like what you want the plasma water to look like. So if the blood, the sodium were 128, and you had a replacement solution of 140 or 144 or 150, whatever you wanted it to be, you can make it whatever you want. And depending on how great that concentration difference is and how fast you replace the solution, the plasma water, will affect how quickly you change the plasma sodium or to the level that you want it to be. And you can mix and match fluids, and I'll talk a little bit about that going forward. So here you take a look at a normal kidney, which is the orange line going off to the right, and that's what the kidney will remove. Size-wise in molecular weight, if you look at diffusive clearance, which is the green line, which is intermittent dialysis, it's really good up to about 6,000 Daltons, but you can see even at 40, at a clearance of only 40%, if something is under 5,000 Daltons in molecular weight, which are pretty small molecules. So diffusive clearance or concentration gradient clearance with a hemoconcentrator or a dialysis kidney is very, very, very weak. Anything larger, like an inflammatory mediator that may be living at 25,000 Daltons, is darn near impossible. In fact, it is impossible to remove with diffusive clearance in any setting. So the black line is convective therapy, and this is that solute drag I was talking about, where you remove large clumps of water under very high pressure, and it forces much larger molecules through the semi-porous membrane of the hemoconcentrator that's used. And this is very important. You have, let me go back. This is very important. If you have myoglobin, for example, convective clearance clears it very, very, very well, whereas diffusive clearance doesn't clear it at all. So here are the various fluids that can be purchased, and there's a whole bunch of others. This is just a few of them. But you can get sodiums of 140, 136. You can get potassiums of 0, 2, 4, 4. So you have a hyperkalemic patient, and you want to lower their potassium, and you want to do it faster than not. You can have two different bags up running at the same time, one of 4, one of 2, give you a 3, and run them both at the same speed. But you can do all kinds of things with this. If it's hyperkalemia, you can use 4. You can even add potassium to the bag if you want to and make it higher, or have the pharmacy do it. Calcium, you can maintain their calciums. If you use citrate protocol, then you wouldn't want to use calcium, but so they give you 0 calcium solutions if you want to do regional anticoagulation with citrate. Magnesium, chloride, lactate is 0. So if you have a elevated lactate for some reason, notwithstanding, I truly believe lactate on its own merit is detrimental. I am going to look this up. I'm going to get out my Guyton's physiology book. I am going to find it. And we're going to revisit this class. But nevertheless, if you want to get your lactate down, you have to have a solution that doesn't have lactate in it. And this doesn't, and you can get it down very quickly, but you can actually have solutions with lactate. I know they exist. Bicarbonate levels you can have at 35, 32, 25, whatever you may want. Glucose, of course, and the estimated osmolality is right there for you to see. Lower than sodium chloride, obviously has less sodium in it, but fairly normal, good normal physiologic solution. Now what's missing there is phosphate. When you do CRRT, you frequently end up with a hypophosphatemia, and you have to give some. However, new solutions being made now also contain phosphate. So they're trying to solve that problem as well. So what is the reason, my question, CRRT is not universally utilized and quickly, especially in the ECMO patient? I'm going to say something else controversial. I believe every patient that goes on ECMO, except for the chronic patients who are getting transplant. I'm talking about acutely ill patients for either influenza-related ARDS, sepsis-related ARDS, whatever that reason may be, or VA ECMO for circulatory collapse, whether it be post-cardiotomy or whether it be they came into the emergency department and coded, or had a PE on the floor, whatever those reasons are, other than those chronic patients, I think every patient, as soon as they go on ECMO, should be hooked up to CRRT at a zero balance, very low therapeutic treatment, but having it available to keep there to very precisely manage their fluid status and to keep their acidemia down, keep their pH normalized, and keep their electrolytes normalized as well. You have to treat the albumin though. If you're third spacing, that's a different issue. I realize it's a different discussion, but it's continuous. It's easily integrated into the ECMO circuit. It has a wider range of clearance to remove the juju, as I call it, or the evil humors, or the inflammatory mediators, or whatever term you want to use. It's a continuous fluid balance management system, and there is no need for an additional dialysis nurse. So I think that helps with cost management, because that's always a concern. But I also think that you manage the patient maintaining their homeostasis much more completely than giving diuretics and giving hypertonic saline or hypotonic saline or any of the other various different interventions we take. I think it gives your environment a much better opportunity to correct the other issues when all of these issues have been controlled. So that's my theory or my belief. What say y'all? So let's go to the open discussion so I can get beat up now, because it's my turn. I see them. They're biting their tongues.
Oh yeah, for sure.
So I'm gonna start with Becky. No, don't start with Becky. I'm gonna start with Sharon, because I need a break. You gotta have my back, Sharon. Don't flip to the other side. Don't go to the dark side over there. Come on, what's your thoughts?
I like using it. I think it's good when we're on ECMO. It allows you the ability to take off water, dry out the lungs, and of course, correct all your electrolytes. It's easy to hook up into our circuit, and it can be run by your ICU nurse. It's relatively easy.
And we can do it too.
Can you go back to the first slide of the talk, please?
Of my talk? Here,
Yes,
I can
please.
do that.
Please.
Here, I can do it myself. I'll do it. Here,
Yeah.
I'll do it. Here, I got it. You want to put that lady back up?
Now the first slide.
Right there.
Okay, I'm gonna have to ask you. I think critical care is a team sport, and I appreciate our nephrologist input, and I have no problem getting a nephrology assistance in the ICU or in the OR. We actually have
Unless they're recalcitrant.
We have developed a protocol using CRT in the OR for transplant, LVADs, and no problem with that. Our nephrologists are very cooperative, but I'm not gonna say, I don't want to say anything. Perfusion is not much 100% cooperative with the situation. They want a nurse running that.
But it runs itself. You only have to change a bag now and again.
I'm just telling you the realities, sir. Okay. You asked me to give you the realities, right?
Yeah.
So perfusion is not 100% comfortable doing that. Okay, so we have to get the nurse for it.
I hear that a lot.
Yeah.
Can I, I don't mean to interrupt you, please forgive me, but I have to, because I'll forget. I hear that a lot. We're running a heart-lung machine where we have the patient's entire life in this little machine. We're giving cardioplegia to arrest the heart and provide myocardial protection so it can be clamped and all of its blood supply eliminated. We have suctions, we have vents, we're giving anesthesia gas, we have the entire physiology of the patient at our disposal and all of their blood supply. And you're gonna tell me, and this is what I hear it all the time, and it makes me angry. And you can't run a little CRRT machine? Come on.
I'm going to have to defer to the perfusion group, and you guys tell me why perfusion is not comfortable running it.
I think we're busy. Sometimes, some cases, you have to have a lot. You need more than two hands sometimes.
Yeah, in some cases.
Yeah.
In some cases, and I think in those cases, that's just a matter of we're busy. I can respect that.
Right.
But if you're not really that busy and you just, I don't really understand this.
Sure.
Is that really appropriate? Or is it your responsibility? Is it all of our responsibilities to learn it, to understand it, and to be able to be part of an overall global team?
But to her point is, those cases that need CRT, they are tough cases with a lot of blood transfusions, a lot of activity going on. Now, you're not going to do CRT on a standard cap. You know, there's a lot of activity going on if you need CRT. So there is
That's
truth.
legitimate. You just need more help.
Yeah.
Have another perfusionist come in and help them.
So, and I'll tell you, running it in the OR, I don't think CV anesthesia loves CRT. CV surgery loves CRT. That's their thing right now. Lower the when the CV surgeon tell you, please put the CVP to 30. Have you ever heard it? No. Every every surgeon wants to lower the CVP. So, I mean, our CVP for our VADs is 15. Do not go above 15 regardless of anything. So we love CRT. And we don't want to correct electrolytes, so slow and easy is very good. And I'll tell you, our nephrologists, they are amazing, and I'm a little biased, because some of them are friends, and they help us in the OR, and I don't think there should be any problem running a CRT. And in the ICU, yes, if you're critically ill on ECMO, I don't think there's a role of continuous CRT for sure.
Or do you think every patient that gets put on ECMO in the ICU in an acute phase situation should have CRRT implemented soon thereafter, if not immediately thereafter?
Absolutely.
What do you think?
No.
No, I know. I knew that. I knew that was going to be your answer. That's why I asked the question. So, Dr. Z, you've been very patient sitting there, and you're bleeding from biting your tongue. So the floor is yours, sir.
No, I mean, I do believe that there is a lot of science behind dialysis, that dialysis changed the world completely. But I believe that oversimplifying the problem is not a solution either. If the patient is managed accordingly to what we are preaching, that the patient should be aggressively cannulated, that we should improve the oxygenation aggressively, you should not lose the kidney. The kidney should continue to work, and the kidney will be a million times superior machine to any form of flavor of dialysis that you can implement. It's not unheard of that you can actually do a run of ECMO without having to deal with an acute kidney injury with acute tubular necrosis. Now, if you sit and you wait and you let your lactic acid go up, well, you know that the PO2 in the kidney is close to 10.
Very low.
The PO2 is 100 in the aorta. So it doesn't take a lot for the kidney to actually say, okay, excuse me, I need to go to the bathroom, you know? But at the same time, just dealing with this story, we have heard it before. Okay, so you have chronic kidney disease, stage 3, stage 4. We're going to do a CT contrast of the whatever, and we're going to put you on dialysis immediately. Those studies do not show absolutely any benefit. It will increase the cost dramatically, but it will not show benefit. I think that there is a role for continuous renal replacement therapy. I think that I have used continuous renal replacement therapy in different indications that you guys use on a regular basis. When I have an acidosis that is totally refractory, where I have a bicarb in single digit, and the patient is pressure dependent just because the pH of 6.8 or 6.7, or sometimes the machine comes back and says, I cannot calculate it because I was not trained to do that. Those people, you actually manage to get away by trying to do some form of renal replacement therapy with a high amount of bicarb without overloading the patient. That there is a role in there, but I don't think that actually draw a blank check that says everybody needs to be on CRRT, and we're going to actually, from now on, every single circuit is going to have a filter, and we're going to actually dialyze every single system. I don't think that that is the way to go.
And certainly I respect your opinion. I, however, respectfully also disagree with it. I think these people are so sick. And I'm just not, again, I'm not talking about the patient who was marginal that we put on ECMO very early. I'm talking about the patients who are really on ECMO because they're on they're sliding down they're on the slide, the big water slide that goes all the way down. And so I think it's a different phenomenon. I think that when you consider the invasiveness of ECMO in itself, and then you talk about adding a CRRT machine to the ECMO circuit with a very low effluent rates, or the fluid replacement rate very low, even if you're not using it for acid base or you're not using it for some of these other things, there's a couple of things that I hear from people which cause me to take a step back and think, can that possibly be true? One of the biggest things is, I don't want to put them on CRRT because that's going to decrease the urine, the renal work. The kidney's going to stop working because you're on CRRT. And I would ask that person, how much blood flow does the kidney get? The answer is all of it, right? It's going to get all of it. And it also consumes an enormous amount of energy. So it needs a lot of blood flow, as you said, with a good PO2. If I divert 200, 300 cc's per minute from my ECMO circuit back into my ECMO circuit, but don't change the amount of forward flow from the prescribed amount, cardiac output of 5 liters, and I turn that on and I increase my flow to make sure that it's 5 liters here, but I'm taking 300 here, so it's not now 4,700, it's still 5 liters. How much less blood flow does the kidney see?
It's not about blood
None.
flow. It's not about blood flow. And I think that if you actually survey 100 perfusionists, the conclusion is going to be that less is better. The more tubing, the longer the tubing, the angrier the blood is going to get, the more pro-inflammatory agents that you're going to have, and that is what is actually killing the kidney.
And I think
it's not the perfusion itself.
But that same argument is, if we're on ECMO with all of that tubing, all of that oxygenator, all of that pump head, which is compared to a CRRT circuit, enormous. The CRRT, the added foreign surfaces added by a CRRT circuit is infinitesimal to an ECMO circuit, and the CRRT circuit actually has the capability of clearing inflammatory mediators, which on any patient on ECMO are going to be screaming.
I just don't believe that. I have a deep respect for the nephrologists, and I don't believe that the 3 years of the fellowship in nephrology is that oversimplified. I believe that the people who actually understand dialysis, understand the 4 modalities of dialysis, they will be able to actually implement the right modality of dialysis when it's appropriate and indicated. Mm-hmm. What I believe that you might actually be experiencing is that some of them are so smart, so intelligent, that they are not very good educators. They cannot convey the message. And we see that with very smart people. You have a very smart person who has a hard time dealing with interns, residents, medical students, because they have so much knowledge in there and they don't have the experience to actually try to make that a way they can be easily digested.
Is that why everybody is having such a hard time understanding me today?
I don't know.
Apparently not. Rebecca, the answer is yes.
Sure.
Yeah, absolutely. Okay, so, well, with all of that said, I think that was a good controversial topic.
Yes.
We certainly are on opposite sides of the fence there, which is good. So let's go around the room. Oh, did we get any feedback on our Slido? Our questions? And believe me, I'm not saying I don't like nephrologists. If I came across that way, I love them. Dr. Kuo is like somebody who I have tremendous respect for. But listen, I don't know where you work, but I go places where nephrologists have said absolutely CRRT is the worst thing in the world and should never be used. And It's like everything. Nothing should always and nothing should never. You have to use everything in the appropriate setting for the appropriate reasons.
Absolutely.
And that's the bottom line. But I have dealt with that a few times. Did anything? Okay. Watch if I ask him again, he'll get I can aggravate him. You got it yet? One person? Well, that's 100%. Who was that one person? Was it you? No. That's pretty weak. I would have probably rather you told me no. 2 people. Does the second question pertain to ECMO only? Either way, I am unsure as I am new at my institution. I have an exit strategy. That was for ECMO. Do you have an exit strategy for ECMO? And somebody doesn't have it, okay. 2 people said they do have an ethics committee. No, they
Nobody.
don't.
Yeah.
Okay, well, just 2 people.
Oh.
Wow.
Do you perform ECMO? 2 people, okay. Yes and no, so 50-50. You know, there's a lot of places. That's good. Yeah, I'd rather you just told me nobody said anything. There were 2. That was painful. Thank you. Anything else you can do to help me today? So anyway, all right, you can cut that. Yeah, take that away. Get rid of that. Put something else on there. But anyway, so with that said, let's go around the room. Any final thoughts? Becky, you are first this time, whether you like it or not.
Okay. As far as like CRRT goes,
Anything about this whole program, about everything we discussed. Any final thoughts on all of this?
I thought that each of the one of the presentations were very well thought of, and all the key points were met. I do have a question about like the antidiuretic hormone and seeing that in patients like with do you deal with patients that are on bypass like post-operatively or ECMO patients as far as kidney function post-operatively? Sorry, that didn't come across very clearly.
That's okay. You want to try again? What's your question?
Just antidiuretic hormone being like, I guess, monitored for our ECMO patients.
So do you monitor ADH?
We don't.
Does anybody? I don't know.
I don't think so.
Yeah, I don't
I
know.
don't think so because by just looking at the osmolality of the urine, you know what
You
the
know what it
ADH
is,
doing.
so you can infer it from
So
that.
you get the osmolality of the patient, you get the osmolality of the urine, and
Yeah.
you know what the ADH is doing.
Sure.
Okay. There is an SIADH that is nephrogenic. You can give a little bit of ADH, and if it's nephrogenic, the kidney is not going to respond. If it's central, the kidney is going to respond to that. But this having some kind of an acute SIADH, I don't think that is something that we see very often. You can actually talk to a lawyer and you can come with that theory that SIADH can happen acutely out of the blue and the emergency room physician will be responsible. That would be short of stupid.
Yes.
But SIADH requires a kidney that is not working correctly for a period of time. If things get out of control and you have brain edema and you're at a risk of herniation, is when the emergency neurological life support guidelines will kick in. We are right now trying to disseminate the guidelines from the Neurocritical Care Society, but you have to intervene. There's no argument about that. And the treatment is not salt tablets. The treatment is not demeclocycline. The treatment is not DDAVP. The treatment is not steroids. The treatment is not water restriction. The treatment is hypertonic. Saline.
But you didn't talk about this, and I had mentioned about sudden correction of the sodium and demyelination syndrome.
Well,
so
I didn't want
because
to
we've
get
got to be
into
careful
that.
about that.
I didn't want to get into that, but here is the problem that you have when you correct sodium really fast, which is what you are trying to suggest with dialysis.
No.
If
Don't time
the
out.
sodium is-
Wait, doctor. Well, I'm not going to let you squeeze that one in. No. The beauty of CRRT is that you can correct it slowly over time and not have to give the patient fluids if the patient can't tolerate fluids at the time. So that's not fair, but go ahead.
Okay. So what is my line of thought?
You were talking about demyelination, sudden
The
rapid
problem-
increase in
yes,
sodium.
The problem with correcting the sodium too fast is that the patient is going to get better like this. And everybody's going to be happy because the damage to the brain is going to happen on day 3, on day 4. Usually, the patient is out of the ICU already. And now you have a patient who is not waking up. The patient was having seizures. The patient was having a change in mental status, was comatose. There is no argument. There is no argument that it was an emergency. There is no argument that we had to intervene. But if the correction is too aggressive, where you see that your patient gets better immediately, the surgeon is going to be happy, or the intensivist is going to be happy, the family is going to be ecstatic about it, okay? But 3 days later is when you're going to see the damage. The patient is going to fall into a coma and is not going to wake up. And that is the problem. And usually, the person who did the dramatic, radical correction of the sodium is not the person that is going to see the patient 3 days later. So this person is blind to the consequences of the action. And if you look at the literature on hyponatremia, what you see is that it took years and years and years of documentation for us to learn that we should not actually correct the sodium. And we have come down dramatically. From the time that I was in med school, we corrected 20 points, to right now, if we are correcting more than 8 points in 24 hours, we should be screaming and panicking, and all the red lights should be on, and all the warnings should be there. We should be giving drugs to slow the correction of the sodium. Making things worse, because of the formulas that we have, they tend to underestimate the correction. On top of that, you have patients that are called overcorrectors, that even if you actually do everything by the book, they will correct dramatically. And those people are at risk of having CPM. They will get better in the ICU. They will be transferred out of the ICU. They will be on the floor the day that they fall asleep and they never wake up.
That's scary. Is there a threshold on that? In other words, you see a sodium of 132 and you want to correct it to 138 versus a sodium of 122 or 120, and you try to correct that to 138. Is there a threshold?
That is a great question. In general, if you ask people, we'll tell you, oh, sodium is greater than 120, we don't have a problem. Yes, we do. So we started with sodiums less than 100, they were dangerous. Then we say sodiums 110 were dangerous, 120s are dangerous. Now we're talking about 125 is actually a risk for the patient, and it should be taken seriously. I would not refuse an ICU admission on a patient with a sodium of 129 if the patient is symptomatic. I will bring him to the ICU, I will do the entire exercise, and I will correct the sodium slowly. Now, if the patient is an acute emergency, that is when the patient has seizures or when the patient is comatose, then the recommendation right now is to raise the sodium fast in 1 or 2 hours, raise it 5 points, and then you stop. In the next 23 hours, you're going to raise only 3 points for a total of 8 points in any 24-hour period. That's why I'm telling you that dialyzing a patient with hyponatremia or hypernatremia is actually tricky. And I will leave it for the geniuses who actually went to the nephrology fellowship and leave me in my fellowship of critical care when I don't need to be that smart to manage my machine.
Fair enough. So in fairness, Rebecca, is this your first time on camera?
It is.
Has it been, has it been a good experience
It's a
for
good
you?
experience.
You dropped your mic. It's always fun to do things for the first time. Exactly.
it is.
Well, I've really enjoyed having you here. I know that it's hard when it's your very first time,
Yeah.
but you can't see anybody.
No, I know.
That's the beauty of it all.
But
you know,
just know they're looking, you know.
yeah, maybe.
Yeah.
We only had 2 people answer Slido, and I think it was our staff. Okay, so Dr. Samir, how would you like to close this out?
I'd like to just about pulmonary hypertension, running ECMO patients. Please, no journal clubs. Do the right thing very quickly, very early, and get ethics involved very early and be honest with the families.
And I'm so glad you brought that up because I agree with you. I agree with you 150%. You don't have time to sit and hand wring and contemplate whether or not to put the patient on ECMO. You got to do it if you're not, or don't do it, one or the other.
Exactly.
And you do. But that's the big problem is the exit strategy.
You need a plan of
You
action.
really have to have it. So if you were counseling or consulting with a hospital that was going to open an ECMO program, start an ECMO program, because that's becoming very popular right now, what would be your 3 pieces of key advice to them?
Multidisciplinary team from everybody, perfusion, critical care, CV surgery, cardiology, pulmonary, nursing for sure, and pharmacy, okay, because our management for drugs. And I'll tell them an ethics person, a strong ethics program. And if you make a decision, patient needs ECMO, you have to have a criteria for who you're going to put on ECMO. You decide you're going to do it. And then meet with the family immediately after. Then this is what we did. These are our expectations. And you have to update the family continuously and show them what the trend is happening and be honest with them. And be true to your numbers. I mean, the numbers that critical care came up with about how many organs lead to the outcome is going to be bad. If you have a 3-organ mortality is very high.
Very.
3-organ failure, the mortality is very high. And actually, I believe the 20-20 number. If you have a total belly of 20, you're not going to survive. Lactate of 20, you're not going to survive.
20 is very high.
Yeah, so you're not.
There are some pairs that we like for example, things that should never happen.
Yes.
Like your hemoglobin and your INR should never be the same.
No, that's a bad sign too.
Exactly.
Exactly.
And I'll tell you, I mean, those 2, the people who make fun of those numbers, the numbers really, they're true and they're good, projection. 2020, then you just be honest with the family. Nobody gets mad about being honest. And that's what I encourage the hospital to do. And have in place a system how these patients are going to be taken care of from staffing point of view, from perfusion and nursing, and how critical care is going to cover those patients.
Excellent points. I'm going to ask you 2 gentlemen to select choice A, choice B, or choice C. Choice A is a perfusion-only ECMO program where perfusion does the initiations with whomever the cannulator is, stays with the patient in the ICU for the entire duration of the ECMO run, is there for the removal of the ECMO, and goes on their way. Choice B is a completely nurse-run program where nursing goes in with the cannulator and does the initiation. They stay with the patient in the ICU through the duration till the decannulation. Choice 3 or B or C, choice C, is a blended program where perfusion and nursing work together. The perfusion comes in for the initial cannulation and stabilization. Once stabilized, the nurse takes over and manages the patient through the duration of their ECMO run. If they feel like they need any assistance or a circuit change or rounds being done, the perfusionist would come in and check it, be available by phone. You would also have an intensivist monitoring the patient via, actually that's going to be choice D. Choice C is everything I just mentioned. The nurse manages the decannulation, but it's a blended program. And then choice D is that blended program with the addition of an intensivist who can call up on his phone and see, or his iPad or his computer, the patient, see the room, see the ECMO, see the flows, see the pressures, see all of the hemodynamic monitoring, review the labs and everything else, should there be the need for a medical intervention of some sort. A, B, C, or D? Which would you choose?
You're asking somebody who actually was blessed with the experience of having to put together an ECMO program. And what we did was to take a group of RTs and a group of nurses that were motivated, and we made them ECMO specialists. With, for lack of a better term, that was the term that we were using.
It's a good term.
The ECMO specialists, and they were actually, with the training, with the experience, they were very good. We trained them in emergencies, and they were able to actually change an oxygenator on a time that was compatible with a perfusionist. Okay, they were things that I was very impressed with in the program was the degree of detail-oriented way of looking at that. They were getting the flashlight and they were tracking the entire tubing system with the flashlight, looking for little pieces of fibrin that were accumulating. They were reporting to us in regular basis. This is happening. This is how it's happening. Look at the oxygenator here. Look at the oxygenator there. It was an incredible experience. I think.
Do you mind if I ask where that was?
Scott and White.
Scott and White. Okay. Yes.
So if the objective is to have the perfusionist in there at the beginning, because it's an intimidating thing, especially when there is a lot of blood on the floor. Once you get your ECMO specialist to a level of proficiency that is acceptable, then your perfusionist can be actually diverted to go to the OR, to be available on call, to be available in the house first, available on call second, and then you actually transfer the program in there because it's more efficient.
I just realized that I met you at Scott and White because I went there and did some locums ECMO coverage when you guys were training your RTs, and I did some RT training while I was there.
And it was
the
a beautiful
beginning,
experience.
the beginning time of it. That's where I first met you. I now remember that.
Yeah, and we did with transport, and there were levels. When you start with transport from one bed to another. We started transporting the dummy from one bed to another. Then we actually did a formal training where we were able to put the patient on the elevator safely, get into the CAT scan and get him out of the CAT scan,
Yes.
put him on the elevator and bring it. That was a level. And the next level, by the time that I left, we were talking about using one of our satellite hospitals, going, cannulate the dummy over there, put it safely in an ambulance, coordinate with the paramedics, with EMS, transport the patient safely to our ICU, get on the trauma bay, get the patient on the elevator, and get it safely into the ICU. There were specific roles and procedures safety procedures that we were actually teaching them, and when they are very motivated, they actually do an excellent job.
That is, those are all, that is I love what you just got through saying. So you do know that we are in the process of opening up a nurse ECMO specialist school. I'm not gonna call it nurse ECMO specialist, ECMO specialist school, because RTs are welcomed, if you will, here in Houston. It'll be the only one that is, the next closest one is 800 miles away. And I think that what works for one place may not work for another, may not work for another. But I do respect very much your opinion about this, and I agree with you 100%. A really good nurse is, as far as I'm concerned, just as capable as a perfusionist if they're trained properly, because they understand a lot of what's going on with the patient already. They're not starting from square one. So I think one hospital may want a blended program, and that works for them. One hospital may want just nurses, and that works for them. One may want RTs and nurses because that works for them. And it really depends on volume and exposure and where your support is. If they're within close proximity, perfusion, for example, it's a lot easier to have a almost exclusively nurse-run program. If they're farther away, then it's less desirable to have that because you don't have that support. But very good points. And I hope you will help us with that education process. But I also think there's places in the country that don't really have intensivists in-house. They have an ECMO patient. You've got to monitor that patient. There's not a perfusionist within 200 miles. You can have an intensivist like yourselves, and since Dr. Samir, you're so into telemedicine, that can actually be monitoring that patient, see trends occurring, tell them what to do from a medical management, but also you need to call somebody in because you're going to need some help doing this, changing it or whatever it may be. What do you say to that?
I say we all have to learn from other people doing things, and we don't have to reinvent the wheel. So Colombia piloted a program where they're doing monitoring of their ECMOs internally. They put chips in the ECMOs that transmitting information to the mainframe. And it's working perfectly for them, but that's an internal program, just for Colombia. So I do see systems and small hospitals that are ready to putting ECMO like we talked about, and they have expertise. And you don't have to have the chips in the equipment. You can have a camera. We can look at the platform, see what's going on. And from the data, you have to be linked to the EMR, see what's going on with your gases, what's going on with anticoagulation, what's going on with the lactate and things like we talked about. So yeah, I think having that available can be part of tele-ICU, which people are not seeing. I think MCS right now, on all levels, should be part of tele-ICU. A dedicated part with people with special expertise. As hopefully the technology can be responding that some of the companies can insert chips in their equipment that can transmit the data to your computer. And that really was going to be amazing, if that happens,
I think telemedicine is clearly, and it's still in its nascent stages, but it is going to have to become a normal thing because there's perfusionists, people aren't going into this field. Physicians, there's a lot less people that want to be physicians these days.
And people thought telemedicine is going to be for smaller hospitals. It's actually not. Bigger institutions right now are using it for their whole system.
Yes.
Yeah.
Yes, absolutely. That's another very good point. But we certainly have a shortage of medical professionals.
Yeah.
I don't think there's any question about it. And I don't see it getting better anytime soon. So, you're last.
Okay. What percentage of awake ECMO do you do?
Insert awake as
in upper body cannulation,
or
ambulating and physical therapy?
Well, ambulating after they're cannulated. Cannulating awake, we're doing almost zero. Okay, that I'll tell you, be honest with you.
Okay.
But early extubation, ambulation, we have an amazing, and Joe knows an amazing physical therapist.
Yes.
We ambulate patients on ECMO 100%. Like if you can ambulate, but like if you don't have a femoral strategy of cannulation, so it's if you have a next strategy, whatever the cannula going to use, it's going to be with a Protec, Duo, Avalon, whatever it is, and everybody thought disasters were going to happen and the things patients are going to spew blood in the sky. That has not happened. Right. It has happened with patients laying in bed, nobody watching them.
Oh, yeah.
Yeah. So I'll tell you the ambulation, and I think not everybody can be ambulated. Yes, he's right. But if you have a young person that you want to get stronger, that you're going to give them a transplant, and you want to maintain the transplant, you need to get them stronger.
Yes.
Right.
Yeah.
Well, you don't want to let them decondition.
No.
That's really it's maybe not necessarily getting stronger. It's keeping them from deconditioning by becoming immobile while they wait in the bed for 30 days to get their transplant. That's really, I think, the issue. It's prevention of deconditioning more so than necessarily.
I mean, you have these patients are so nutritionally impaired that they get the skin breakdown, the cubitus.
Exactly.
And now you start thinking, oh, you're an ECMO or you're an MCS, you have to do a diverticulostomy to avoid that. I mean, that's it. It's over at this point. And it's all because you could not really get out of bed and you ambulate and all that. So, I mean, I'll tell you, I believe in getting out of bed is the cure of all evil, but you have to choose your patient.
Yes, you do. And I think that is the takeaway message from that is that people hear things, oh, they're getting their ECMO patients up in chairs. Okay, but we're not talking about this kind of patient that you just got. This patient got a white count of 25,000. They're really, really sick. They have an acute inflammatory process of their lungs. They're in heart failure now too. They're in acute renal failure, acute kidney injury. I don't think they're
Plus,
getting up.
we've got to respect age. Age will always be on your side. Younger you are, I mean, definitely going to be on your side. We have to it's the state of life, you know what I'm saying?
Yes.
So
Yes.
if you have like a 25-year-old is different than a 65, different than a 90-year-old.
Yes.
I don't care what people say. It's a 90-year-old. She's so active. She walks around every day. So what? She's 90 years old. There's a 90-year-old body.
Yeah.
90-year-old protoplasm. You know what I'm saying?
Is she going to be able to
Yeah,
recover
exactly,
from it?
exactly.
Right. Is she gonna?
Yeah.
Right. What's her meaning? What is the chances of her having?
Meaningful recovery.
Right. I mean, right. Exactly. That's the big problem.
Exactly.
The big question.